कोई अनम्यूट करके मुझे जवाब दे दे या जो है वो चैट बॉक्स में बता दें कि एवरीबॉडी कैन हियर मी एंड सी मी। जैसे चैट खोल के इसको यहाँ कर देंगे आपको आता है। Okay, so I welcome you all. My name is Professor Fawad Ali Musa. I'm Chairperson Surgery Department in Dow University Health Sciences. So I'm just going to give you a little brief up before your class starts. Dr. Zahid Memon is here. He's going to take your first class on history taking in a surgical patient. So I just wanted to give you a little brief up what our objectives is and aim is here. Basically, we're going to start the history taking today, and then the next session Dr. Munira is going to take tomorrow, and that will be on general physical examination. And then gradually we're going to go further. We will share you with the topics as well. Soon we are just finalizing those topics for your sessions online. Now, one thing I want to make it clear, obviously online, what we are doing now because of the COVID thing, as you all know, we can only explain you, demonstrate how history is taken by explaining you through pictures. It could be pictorial, could be video clips, and by interaction with all of you. But obviously, eventually, when the COVID period soon ends, we're going to you're going to be posted in the wards, and then we'll let you demonstrate and show all these things we are going to teach you, whether it's history or examination. So one thing before we start, why history taking and examination, what basically you need to know and why is it important. So for this first, I would like to give you one name of the book, which you as a reference, which you have to look, and that is Norman Brow's Clinical Methods in Surgery. Norman Brow's. It's available in the market. You can buy it, and that's very important. And in the first chapter, there is all about history taking, and then we start with the history of the lump and so on. So why history taking is important is because any patient who comes to a surgical OPD, you don't know whether it's medical patient or is a gynecological problem, it's a surgical problem, psychiatric problem, orthopedic problem, whether it is acute or chronic. So you start with obviously knowing, about various things about the patient. Dr. Zahid is going to tell you how we start and what are the things important. And important thing what I want to stress is here that your history taking and examination is a very major role, which you need to have that expertise now from third year onwards. The reason being that unless you have a good history and a good examination, you cannot go further. What do you mean by further means you come to a differential diagnosis and then a provisional diagnosis. And then you start planning your management, which starts with investigations, various, whether it's radiological or blood investigations. And then you talk about management, whether it's a medical management, it's a surgical management, and then what are the surgical various options, what are the complications, what are the prognosis. So for that, all this management, you need to have a good history. Unless you don't have a history, so you and you don't have a proper examination finding. For example, if a patient comes with a pain in the right lower abdomen, you have to have a good history. Like if it's an appendicitis, so you need to know what type of pain it is, whether it's radiating, what is the history. So Dr. Zahid is going to tell you all about that. So unless you know what the classical appendicitis presents at, like I just told you, right lower abdominal pain, right iliac fossa pain, but it starts with the middle, in the middle, like in the umbilical pain, and it initially starts, and then it is shifted to the right iliac fossa. So he's going to tell you what shifting means, what refer means, what radiations. So you need to know all that. What is a referred pain? What is a shifting pain? And then all these symptoms, and then you start examining, and whether it is tenderness, what is rebound tenderness. Later on, when the examination, you're going to know about all that. As we go on. So once you have those findings, then only you can say whether it is an appendicitis or it is a female, it is some ovarian problem, some it is a urinary tract infection, it is a kidney stone, and what it is, or is it some other problem like is it amoebic nephritis, etc., etc. So I think that from it, I just want to see whether our coordinator is here. Dr. Junaid, are you online? Dr. Junaid, if you are online, please unmute. Dr. Junaid. I think he's still not online, but I'll ask him to come online and if I share with you his mobile number and email. He's a coordinator for third year online clinical teaching. So if any queries, anything, and soon we'll be uploading as well these on the LMS. So from here, I say goodbye to you and all the best to you, and over to Dr. Zahid. And if you still have any queries, I'll if even Dr. Junaid doesn't join, we'll put his mobile number and his name, Dr. Junaid Zaman. He's a coordinator for third year teaching. So any question you want to ask me before we start the first lecture, tutorial? You have any queries? Okay, so goodbye from me and over to you, Dr. Zahid. Thank you, everybody.
Okay, assalamu alaikum, and welcome to the first class. I think this is the first class of third year, so you know that there's a lot of enthusiasm to join the class, and everybody should know that first thing that when you come in the ward, then it looks like to be that we are doctor. Please learn something that is very important. One is, basics is somehow different as compared to the clinical postings. Clinical posting is very important, very interactive, very interesting. Here you can enjoy. So first thing that I'm going to notice is about the history taking. That is ABC in any class, of whether it's a surgery or medicine. Someone is asking about what's a book. So it's Norman Browse, NORMANBROWSE. Norman Browse is internationally recommended book. So that's very important for you to remember. And so if there's any question during the class or even after the class, you can ask me at any time. My name is Dr. Zahid Memon, and I'm working as an associate professor in Surgical Unit 2. And when you are coming, if this pandemic is over, you can ask me at any questions, and you can even join the operation theater, inshallah, and you can enjoy the class. So in between, if there's any question, please let me know. I'll be happy if you're asking any questions. So should I start? If you can chat yes, then I can start. Okay. So starting from Bismillahir Rahmanir Rahim. So today we do talk about the history taking. So what is the objective of history taking? Everyone should know that establish a positive professional relationship, to provide the clinician with informative concerning the patient's past medical, surgical, and personal history, to provide the clinician with the information that may be necessary for making a diagnosis, to provide information that aids the clinician in making decisions concerning the treatment of the patient. Because in my view, 99% of your diagnosis is based on a proper history. And history taking is an art. You have to grab the information from the patient. It's not simple. It's very important that how to go on. And approach should be good. Professional approach should be good. And then you have to take every information from the patient, not asking leading questions from the patient. Ask the patient, give time to the patient so that they can explain their problems very well. And don't use medical terminologies over here, because it should be a layman term. You have to ask in patient's own language, and you must be very much cautious, a good listener, so that you can make a good provisional diagnosis or differential diagnosis. So I divide this history taking into different parts. One is introduction and describing aim and objectives. So first will be the presenting complaints, like the chief complaints, like it could be a pain, it could be a vomiting, fever, or patients can have a swelling, a lump in surgical patients. Then history of present illness, that should be in a detailed manner, in a detailed view. And then the third component, fourth component is past medical history. And you divide this into past medical as well as surgical component. Then we come to the systemic review or systemic inquiry. After that, we have family history, drug history, personal history, or social history. And then we have to go back. So, present complaint, history of present illness, remaining questions of abnormal system. Then systemic review, past medical history, past surgical history, drug history, history of immunizations, family history, social history, or habits. All these are the main components that we have to cover. Can anybody tell me that, are you sure that you have read Naumann Browse from surgical point of view, or no? Or have you started your studies so that it is very important for me to communicate with you? Anybody? You can just state yes or no. Okay. Many of you have write down yes, and many of you write down no. So it's okay if you're not started, then please start reading. And this is the time you can learn, you can establish your diagnosis. And once you are in third year, then it becomes very easy for you to understand the diseases. And that's very important. So, the students at the end of the session should know the fundamentals of history taking and take a history of a simple disease to reach at the diagnosis. And obtaining an accurate history is the critical first step in determining the etiology of a patient's illness. A large percentage of the time, 70%, you will actually be able to make a diagnosis based on history alone. So history is so important. It's an ABC. General approach. The first thing that you have to go for is introduce yourself. Never forget patient's name. You know, if you ask the patient their name, it creates a good relationship from the patient. If you ask the patient, okay, Junaid, what's your name? You say that Junaid, what happens? What do you think is the cause of the pain? Where is the pain? So this gives a good relationship. And create patient appropriately in a friendly, relaxed way. Confidentiality and respect the patient privacy. Try to see things from patient point of view. Understand patient underneath mental status. He will be in anxiety, irritation, or depression. Always exhibit neutral position. You should be a good listener while you're taking the history. And then you have the right to ask frequent questions. Simple, clear, avoid medical terms. Leading, interrupting questions should not be there. Direct questions. So you don't have to interrupt the patient, but sometimes if the patient is not giving proper information, then you can interrupt at the same time. I hope you understand, because this is very important. First step is you should be a good listener. You should be appropriately mannered, and you should be able to avoid the anxiety of the patient, right? So this is very important, and very important is privacy of the patient, you know. So taking the history and recording, always record personal details. This is very important because you have to keep the record of the patient, and this is very important from any surgical perspective point of view. Always record personal details. That indicates like name, age, address, sex, ethnic origin or ethnicity, occupation, religion, marital status, date of admission, mode of admission, time of admission, and date of examination. This should be properly documented. That's why I'm giving you the first information. This is known as a personal biodata. And personal biodata should be clear and it should be informative. That is very important, that you should be able to give very good information related to the patient. Why I'm asking about the name? Name is the identity. And it will tell you whether this patient, you have to, while you are taking the history, it's important that you can name the patient. And then age. Age is very important. Some of the diseases, they are very common in the younger age group. Some of the diseases are very common in older age group. And some of the diseases, they are very common in middle age group. Like, I'm giving the example like in infants, congenital heart diseases are very common. So one should look from that point of view. In children, trauma is very common, like burns. And in middle age, road traffic accidents are very common. Old age, atherosclerosis, hypertension, diabetes mellitus, and coronary artery diseases. All these are very common. So that's why age is very important. Mentioning the age gives you some clue that what is happening whether the patient is suffering from comorbidities, yes or no. And address is very important. Like some of the people, they are living in defense, like they have low activities. So it could be obesity, hypertension, and heart disease, they are very common. If the people, they are living near airport, so you can see barotrauma. Ear trauma is very common because of the noise pollution. If the people, they are living in Korangi, then pollution is a lot of, so they can suffer from asthma, they can suffer from in a lot of infectious diseases. And then sex is very important because some of it is they are very common in male population, and some of it is they are very common in female population. Just I'm giving the example, like carcinoma of the breast is very common in females, carcinoma of cervix is very common in the females, like, and then you can see sexually transmitted diseases. And then in the male population, carcinoma of the prostate, bronchogenic carcinoma because of cigarette smoking, this is commonly seen in the male population. What do you mean by ethnicity or ethnic origin? Ethnicity or ethnic origin gives you a clue from where the person belongs. Like I'm giving an example. If the people, they are living in interior of Sindh, they have a higher percentage, they are suffering from renal stones because there are a lot of infectious diseases are very common, diarrhea is common, they are dehydrated and because of the heat. And then in urban population, gallstones are very commonly seen because here there are a lot of barbecues and you know that diet is different from their lifestyle is different. They are taking high fast foods. So that is very common. So that's why gallstones are very common in urban population. If you move to Balochistan, then you can see there are sheep-rearing areas, hereditary cyst is very common. If you move to Kashmir, then if they are living at high altitude, polycythemia is very common. So the ethnicity is very important. You have to take a good that from where the person belongs. Then occupation. You might have heard about occupational diseases, like if the patient who have a long-standing profession like traffic policeman, then varicose veins are very common. If they are working in industries, then asthma is very common. Coal workers, pneumoconiosis. If they are keeping the birds in their home, then psittacosis is very common. So all this is very important. Then religion. Being Muslims, we do practice circumcision. So carcinoma of penis is less common. Like in Hindus, carcinoma of the penis is very common. And then marital status, if the patient is married, whether he is married or not, then sexually transmitted disease should be sought out. And then date of admission will give you whether the patient is being admitted in early stage or later stage. And mode of admission will tell you whether this is an emergency or patient is admitted through OPD, whether this is a cold case, and then time of admission, whether he is admitted at night means it's an acute emergency. And then record the date of examination because examination will tell you whether your patient is improving, yes or no. This is very, very important from any point of view. That gives you a very important information related to this. Up till now, any questions you can ask me, please let me know. If you have understand this general biodata recording and the causes, then write down yes. If there is any problem, then please let me know so that I can move forward. Is that okay? Okay, now I can move back to the next slide. Then after you have taken the general biodata, like name, age, sex, religion, occupation, address, ethnicity, then you have to move about the complete history taking. So the first thing that comes in your mind is chief complaint of the patient. Usually in surgical wards, yes, mode of admission, the importance is, one of the questions is mode of admission. For example, if the patient is admitted early in the morning, means in the morning hours, there could be, and we say that mode of admission through OPD or through emergency. OPD means it is like a cold case. It's never an emergency. But if he is admitted or she is admitted in the night or in the evening, could be because of acute appendicitis, perforated appendix, peritonitis. All this is very important and it will show you the mode of emergency, whether he is admitted in emergency or yes or no. I hope it is clear now. And then if they ask you about the complete history taking, about the chief complaint, then history of present illness, then you have to ask about the past medical history, surgical history, and systemic review, family history, drug history, social history is very important. Chief complaint. Chief complaint means you have to elaborate to your patient what brings you here. What is the main problem? You come over here in the hospital. Because there could be a lot of complaints, but what comes first? So it should be in a narrated order. And for example, it could be abdominal pain, it could be vomiting, it could be a mass, it could be a lump. So you have to elaborate what causes you, what brings you over here. That's very important. So, and then comes history of present illness. In history of present illness, the main tips, you have to elaborate on the chief complaint in detail. For example, if the patient has got a pain in the lower quadrant of the right side, so in this case, you have to elaborate the pain. Where is the pain, site of the pain, aggravating and relieving factors, what causes the pain, and duration of the pain, timing of the pain, frequency of the pain. And then ask relevant associated symptoms. Is it associated with vomiting? Yes or no? And then, because it gives you some clue to make your differential diagnosis. And then decide and weight the importance of minor complaints then. Like I'm telling you, for example, if the patient has got fever, so there are a lot of questions that you can ask, whether this is continuous, whether this is intermittent, whether this is quartan fever, and then high-grade fever or low-grade fever, and whether it is associated with chills, whether it is associated with some other complaints. So this is very important. This gives you some information, and you reach the diagnosis. History of present illness. Again and again, I'm telling you that avoid medical terminology and make use of descriptive language that is familiar. And if they ask you, rigors and chills, like I've told you that in malaria, patient can have rigors. It is associated with chills, cold, and pneumonia. Yes, it is associated with this. But if the patient has got cough, if the patient has got pain in lower side of the abdomen, then this is usually a pneumonia. And then each symptom should be focused. Each symptom should be terminology in a narrative order, in a chronological order. What comes first? Like fever comes first or pain comes first? If the fever comes first, then fever comes in the first list, and then you have to elaborate all the questions. Then about the pain. So features of pain, site is very important. First comes is the site. Where is the pain? You might have studied the anatomy. Abdomen is divided into 9 quadrants by 2 vertical lines and 2 transverse lines. So site is very important. Whether the patient has got pain in the right hypochondrium, right iliac fossa, and is there any pain, that is very important. So this is very important for you to remember about the site, because site gives you very informative information. Record the time and date of onset and the way the pain began, whether the pain began suddenly or gradually. Duration, record the duration of the pain. Then severity of the pain is very important. Severity means like the pain is so severe that disturbs your normal lifestyle. If he says yes, it means it is severe. But if it doesn't, it means it is moderate. Nature and character of the pain, whether this is aching, burning, stabbing, constricting type pain, throbbing pain, distending, colicky. Colicky is very important from surgical point of view. It's just like marrow-like pain, spasmodic pain. And this occurs if there is any pathology in the hollow viscera. That is very important. Then you would ask about radiation of the pain. For example, the patient says that I've got pain in the chest, and that radiates to the lower jaw. So this is because of ischemic heart disease. And if the patient has got pain in the right hypochondrium, that radiates to the back. It means this is acute pancreatitis. So radiation is very important. So record the time and direction of any radiation of the pain. Remember to ask if there's a nature of the pain changed at the time. It moved. So that's very important. And then comes referral. Was the pain experienced anywhere else? If the pain is in the chest, then it is associated in the left arm, refer to knee ora. If the patient has got pain in the right iliac fossa, it is referred to the umbilicus, because this is a main sign in history that this is acute appendicitis. And Progression of the pain. Describe the progression of the pain. Did it change or alter? Initially, it's not so severe, then it becomes severe. And the end of the pain. Describe how the pain ended. Was it spontaneous or brought about by some action of the patient or doctor? And then you have to ask about exacerbating relieving factors. For example, if the patient has got a gastric ulcer, in gastric ulcer, if you eat food, the pain will aggravate. And if the patient eats like milk, the pain is subsided. And in acute pancreatitis, if he is leaning forward, the pain is relieved. If he is supine or in a laying down position, the patient's pain becomes severe. So likewise, you have to ask about different actions so that you can understand what is going on. And at the last, you ask about what do you think is the cause of the pain. Then the patient will say, because maybe of trauma, maybe I've got a burning in micturition. Then you can understand that this might be because of the UTI. So this is very important. There's one question that how do we know that the pain is referred or it's the actual location of the pain? You know, if you have an idea about ischemic heart disease, the pain usually occurs in the chest, in the center of the chest. If it is radiating or shifting towards the left arm, the same phenomenon. So you have to correlate, right? In ischemic heart disease, pain can occur in the left arm. Pain goes to the lower jaw. And in acute appendicitis, if the pain is present in the right leg fossa, it goes to the umbilicus, or from umbilicus to the right leg fossa. This is because of the dermatome. Because the midgut rises from, you can see, is a T10 dermatome. Umbilicus supplied with the T10 dermatome. So that's why we say whether the patient has got referred pain or shifting of the pain or radiation. That's why we say that in that. Yes. There's another question why the pancreatitis pain is aggravated while lying down. Remember that, if the patient is lying down, pancreas is the retroperitoneal organ. Retroperitoneal means it's not being covered by the peritoneum. So the pain aggravates while lying down. If you do in a lying down position, forward position, stooping position, the pain is going to be relieved. So this is the mechanism. How does the patient is having, whether the pain is aggravating or relieving. In duodenal ulcer, if you eat food, the pain is relieved. That is very important, right? So very, very important for you to remember that in pancreatitis, if you bend forward, then the pain is going to relieve. If you lay down, the patient's pain is going to be increased. And then in duodenal ulcer, if you eat food, the pain is going to be relieved. In gastric ulcer, if you eat food, the pain is going to be aggravated. So a lot of things can be diagnosed by just putting on a proper history. That is very important. If you do understand this, then please let me know so that I can move forward. Because this history taking is an art. If you do understand the art, how to take the history, how to take the information from the patient, that's very important. Then comes past medical history. In past medical history, you divide this past medical history into two components. One is past medical history and second is past surgical history. In past medical history, you have to ask about any history of ischemic heart disease, any heart attack or myocardial infarction. Are you suffering from diabetes mellitus, any history of asthma or hypertension or rheumatic heart disease? So this is very important. It gives you some clue that what is going on in these terms. Yes, देखें जो उर्दू में क्वेश्चंस आप पूछते हैं ना वो ये होता है कि आपको मरोड़ की तरह दर्द होता है, आपका दर्द कहीं और तो नहीं जाता, और इसके बाद आप ये कहेंगे कि आपके सीने में जो दर्द होता है वो बिल्कुल ऐसे लग रहा है जैसे कोई चीज आपको खींच रही है, जैसा कोई भारी चीज आपके सीने पे लगी हुई है. आपके पेट का दर्द जो होता है वो किस तरह आता है और चला जाता है. दिस इज स्पाज्मोडिक लाइक पेन एंड देन कंटिन्यूअस रहता है, एक ही जगह पे रहता है. This is a continuous sort of pain. So this gives you some information. Slowly and gradually you can learn this. And if you put on a habit of asking questions, then you can learn in Urdu. That is very important. शिफ्टिंग, ये दर्द सीने पे था, अब वो कहीं जा रहा है, पहले यहाँ पर था दर्द, अब कहाँ जा रहा है। तो इस तरीके से आप क्वेश्चंस पूछते रहे पेशेंट्स ओन लैंग्वेज में। तो ये जब आप वार्ड में आना शुरू करेंगे या वैसे ही अपने दोस्तों में पूछेंगे, तो आस्ता आस्ता सारी चीजें आपको समझ में आनी चाहिए और आपको आएंगी भी समझ में। ठीक है। इसके बाद आप ये पूछेंगे कि पास्ट सर्जिकल हिस्ट्री में व्हाट इज देयर एनी हिस्ट्री ऑफ प्रीवियस सर्जरी, इज देयर एनी हिस्ट्री ऑफ प्रीवियस रोड ट्रैफिक एक्सीडेंट, आर यू फॉल फ्रॉम हाइट, कोई ऐसी चोट आपको लगी थी या नहीं लगी थी, पहले कोई ऑपरेशन हुआ था या नहीं हुआ था, कहाँ पर हुआ था, कितना पुराना था, और कोई स्कार आपके पास है तो वो मुझे दिखा दें, कोई आपके पास रिकॉर्ड पड़ा हुआ है तो वो हमें बता दें। इस तरीके से आपको बोलना है, बिकॉज यू हैव टू एलैबोरेट, you have to get the information from the patient, because the discharge card give you a very valid information. When the patient is being operated, where the patient was being operated, what were the clinical findings, what was the surgery being done. So it is very important that you have to ask the patient any previous surgery, where it was done, when it was done, and any surgical record of the patient. So operation history is very important, right? And no, circumcision is not included in past medical history, because if the patient is Muslim, you have to remember that circumcision is being done. But if you think, because that is not, but usually we don't ask about any history of circumcision in past medical or past surgical history. And then history of trauma and accident, that is very important. Again, I'm giving you very valid information that this is very important. You have to ask about the time, place, and what type of accident has occurred. Is what a high-speed accident or a low-speed accident. This is very important. And then comes the drug history. In drug history, always use generic name or put trade name in brackets with dosage, timing, and how long. This is very important that you have to ask from the patient, because at this time when you are coming in the first in the ward, you don't remember about the names of the medicines, but you do remember somehow. Because in Pakistan, you know, self-medication is very common. You might have to know about the ulcer के लिए मुझे जलन होती थी, उसके लिए दवाई लेता था. तो it means mostly like Zantac हो गया, और अब तो वो exclude हो गई है, लेकिन Ryzec capsule, Omeprazole, वो आपके पास हो गया. कभी कभी वो कहते हैं जी चावल की दाने की तरह गोली होती है, that is corticosteroids, prednisolone. और कभी कभी वो पेशेंट कहते हैं जी ब्लड प्रेशर के लिए दवाई ले रहा हूँ, वो उसमें भी फिर डिफरेंट ग्रुप्स आते हैं, कैल्शियम चैनल ब्लॉकर्स आते हैं, बीटा ब्लॉकर्स आते हैं. सो ऑल दिस इंफॉर्मेशन शुड बी चेक्ड आउट. एंड देन very important history that you take from drug point of view is OCPs. OCPs means oral contraceptive pills, and history of vitamins, and you have to ask about Escard, Disprin, and warfarin, heparin. These are the main drugs you have to ask about, because if the patient is taking Escard or heparin or warfarin, then these drugs should stop before you do the surgery. That is very important. So please remember the names of the drugs, dosage, and the timing. If the patient has got information, yes, otherwise you can say that, okay, whatever the medicine you are using, please let me know, so that you can see and the trade names and Escard names. This is very, very important for you to remember. And then comes about family history. If they ask you family history, in family history, they will ask you about like, is there any disease that runs in the families from parental point of view? And then in this case, any familial disease that runs in the families, like any family history of breast cancer, ischemic heart disease, diabetes mellitus, hypertension, schizophrenia, and developmental delay, and asthma, because these diseases, they run in the families. That's very important, because you have to know, in this case, about the familial disease. Is there disease they run in the families? Is there any history of breast cancer, ischemic heart disease, diabetes mellitus, hypertension, schizophrenia, developmental delay, asthma? These should be elaborated, because this gives you some clue that in future one should be cautious about that. If the patient is having asthma, then before going for surgery, patient should be given bronchodilators. So this is very important from surgical point of view. What about social history? In social history, one that you have to ask about the diet history, whether the patient is taking normal diet, or if the patient is taking high diet, high fiber diet, low fiber diet, or if the patient taking fatty foods. Habit of smoking is very important, and you have to ask about how many cigarettes per day. And if they ask you about packs per day, then you have to ask about bowel and micturition habits. Is they normal? If they are suffering from constipation, or if they are suffering from diarrhea, and how many times bowel are going to be moved. And then in micturition, they will ask you about polyuria or anuria, oligouria. If the pus coming in the urine, there's pyuria, chyluria. All these are very important. And if the patient has got blood in the urine, it means patient has got hematuria. All this is very, very important from this point of view. And then ask about sleep, whether the patient has got normal sleep or abnormal sleep, whether he's able to sleep at night, taking normal sleep, yes or no, or he's awaking. This is very, very important. And then ask about marital status. Marital status is again very important, whether the patient is married or not. And then in the females, one should ask about menstrual history, about regularity, menarche, menopause, number of pregnancies, and number of normal cesarean sections. This should be very, very important from your point of view. That should be checked out. So all this comes in the personal history. You have to ask. Again, I'm repeating, diet history is very important, history of cigarette smoking, and in cigarette smoking, you have to ask about number of cigarettes per day or number of packs per day. And if they are using alcohol, then how many drinks per day. Then bowel and micturition habits, sleep, allergy, any history of allergies, because you know that most of the time patients, there are allergic to the penicillins or cephalosporins. So this gives you some clue that if you, while prescribing the medication, you should avoid all these spreads. And then marital status, you should be checked out. And finally, in the females, you have to ask about the menstrual history. That should be very, very important for you to remember. So, and then finally comes in the addiction, whether they are addicted to the pan or addicted to the chalia cigarettes, because you know that mouth ulcers, mouth cancers are very common if the people they are addicted to the pan or chalia. So these points should be kept in your mind. That's why personal history is very important. Now, any questions related to the up till now, like personal history, family history, and any past medical history, past surgical history, please let me know. If you do understand, write down yes. If not, then please let me know some questions so that I can answer and I can move forward. Yes, LSCS is lower cesarean section. You know that in females, most of the time they go for cesarean section. So one is low cesarean section, high cesarean sections. This is very important. Okay, thank you. About the social history, I told you that in smoking history, one should ask about the amount, means number of cigarettes, how many duration, 2 years, 3 years. And you know that type A means is a person who is in anxiety, who wants everything in hurry up. So this is type A personality with history of cigarette smoking. He is at increased risk for getting ischemic heart disease. Then alcohol history, amount, duration, type, and this causes cardiomyopathy, vasodilatation. Occupational history is also very important. Social background is very important. Family history is also very important. After you have taken all this, then comes the systemic review. In systemic review, there's a guide not to miss anything. Any significant finding should be moved to history of present complaints, past medical history, depending upon where you think it belongs. Do not forget to ask associated symptoms of present complaint with the systemic involved. When giving verbal reports, say no significant findings, systemic review to show you did it. However, when writing a patient notes, you should record the systemic review that the relieving doctor know what systems you have covered. In surgery, most of the time you can encounter GI-like symptoms like pain in the abdomen, vomiting. You know, GIT comes first. So you should be very much familiar while asking systemic review questions related to the GIT. Here, I have covered almost all. For example, generally, you have to ask about the weakness, fatigue, anorexia, change of weight, fever, any lumps, and night sweats. If I have to cover the gastrointestinal system, systemic review. So you have to ask about appetite, like anorexia or weight change, and then diet, nausea, vomiting, regurgitation, history of heartburn, flatulence, difficulty in swallowing, abdominal pain, abdominal distension, change of bowel habits, emetemesis, melena, hematochezia, and jaundice. Some of the terms may be new for you. For example, you have to talk about if a patient is passing blood in the stool, it means this is hematochezia. If there's a fresh blood in the stool, it is hematochezia. If the patient is passing black color stool, this is melena. And if the patient is having blood in the vomitus, it is hematemesis. This is very important to ask about in this condition, right? Yes, it's very important that privacy should be maintained, and then you have to ask about that any family member, they can go and then you can ask about history of alcohol use or history of cigarette smoking. This is also very important for you to remember, but you have to elaborate. So these conditions should be known to you: hematemesis, melena, hematochezia, and jaundice. So this is very important. This is not hematochezia, this is a spelling mistake. This is hematochezia, Chesia, hematochezia, right? And in cardiovascular system, one should ask about chest pain, paroxysmal nocturnal dyspnea, orthopnea, shortness of breath, cough, sputum, color of sputum, blood in the sputum, and shortness of breath, swelling at the ankles, palpitations, or cyanosis. That is very important. And if they ask you about respiratory system, then again, cough, whether this is a dry cough or productive, sputum, color, amount, smell, hemoptysis, chest pain, shortness of breath, again, dyspnea, tachypnea, hoarseness of voice, any wheezing, all these conditions should be sought out. Urinary system, one should ask about frequency of urine, dysuria means difficulty in urination, urgency, hesitancy, terminal dribbling, nocturia, back or loin pain, incontinence of the urine, character of the urine, color of the urine, and then amount of the urine like polyuria, anuria, fever. Genital system, one should ask about pain, any discomfort or itching, any discharge of pus, unusual bleeding, sexual history, menstrual history like menarche, last menstrual period, duration, amount of cycles, history of contraception, and obstetric history like what about the para, gravida, any history of abortion. Then nervous system, visual, smell, taste, hearing, and speech should be sought out. And in nervous system, one should ask about the headache, whether this is associated with fits, or whether the patient becomes unconscious, any blackouts, loss of consciousness, muscle weakness, numbness, paralysis, abnormal sensation, tremors, change of behavior or psyche. All this should be sought out. If you don't understand, then it becomes a matter of fact, because it's not a surgical patient. It's basically you have to elaborate all this. Patient can have headache because of hypertension. Patient can have loss of consciousness because of any neurological deficit. And then musculoskeletal system, you should ask about pain, muscle, bone, or joint, any history of swelling, generalized weakness, movement, any deformities, gait abnormalities. All these things should be sought out while you are taking the proper history. This is very, very important. And then history, I've told you that you have to be very much familiar with this. You can understand different problems. So unless you have all the systems involved, you can understand what is going on. And then comes so. This is the, final conclusion that is there. If you have taken systemic review, so once again, I'm repeating, one is general biodata. That includes name, age, sex, religion, occupation, address, ethnic origin, marital status, date of admission, mode of admission, time of admission, then chief complaint or main complaint. And then comes history of presenting illness, HOPC. Then comes past history, divided as past medical and past surgical history. Then comes the drug history, history of allergies, immunization, and personal history, family history, And then I've told you that systemic review should be sought out, and every system should be covered. But the main system that you have to focus is the GIT, because here GIT is mainly involved in this case, in like abdominal pain, vomiting, and all these things. And here, this is a conclusion basically while you are taking the follow-up from the patient. For example, if you're coming in the ward, you have to take the follow-up of the patient. It comes in the formula of SOAP: subjective, objective, A for assessment, and P for plan. Subjective means how a patient feels or thinks about him. How does he look like? Includes weathering complaints and general appearance, condition of the patient. Objective means relevant points of the patient complaints, vital signs, physical examination, daily weight, fluid balance, diet, laboratory investigation, and interpretation. Then comes assessment. Address each action problem after making a problem list, make differential diagnosis. Then comes the plan about management, treatment, further investigations, follow-up, and rehabilitation. This is very important. You being in third year or final year, this should be followed up. This is very important. And now, up till now, if there are any questions, you can ask me. After that, I can move back to the video. Yes. Any questions, please let me know. No. Should I go for the video? Now I can move back to the video. Just a moment. Yes, one is asking about what's the difference between syncope and vertigo. Vertigo means chakarana, okay? And this vertigo is has got different types. And then if they ask you about syncope, means behosh hona. Patient जो होते हैं वो थोड़ी देर के लिए बेहोश हो जाते हैं, so that they can understand कि उस देर में क्या हुआ था. Syncope means faint attack for some time, and after this they cannot do it. Sir, is the SOAP approach, how is the history taking? No, SOAP is not part of your history. It's just I'm giving you how to take the follow-up from the patient. And I've told you in the start, this is Norman Grouse. It's an internationally recommended book for history taking. Okay, I think this is clear. Now I will move back to the other terms so that you can go back. Norman? You just have to watch the video, and then anything that you don't understand, please let me know. Video.
Hello, Mrs. Nancy. I'm Dr. Hudson. I understand you're having some pain. Oh, yes, I had stomach pain. Yes. When did it start? Last night. About what time? 9. Where was it when you first started? It was kind of generalized all around. Yeah. Okay. Did it change at all? Yeah. Well, how did it change? Well, this morning when I woke up, it was more central, and now it's more here on the right side. What kind of pain is it? It's really, it's right there, and it's constant. It's constant. Is it like a grabbing pain, a stabbing pain, a dull ache? Dull ache. Is it going around the back?
Okay, I will show you just a video. I think you have to share just a moment, please.
I was feeling.
Like the yellow जो आ रहा है ना, विषम yellow जो आ रहा है, ये रहा, हाँ. आप पूछें ये आ रही है?
Now you can see the video, yes or no? If yes, then write down yes. You can't see.
करिए तो शेयर स्क्रीन यूट्यूब अब आ रही है पूछें अब पूछें आ रही
Now you can see the video. Yes, thank you.
I understand you haven't seen
Okay.
it. Oh, yes.
Voice बंद कर दो.
Then voice full.
When did it start? Last night. About what time? 9. Where was it when it first started? It was kind of generalized all around. Yeah. Okay. Did it change at all? Yeah. How did it change? This morning when I woke up, it was more central, and now it's more really on the right side. What kind of pain is it? It's really, it's right there, and it's constant. It's constant. Is it like a grabbing pain, a stabbing pain, a dull ache? Dull ache. Is it going around the back at all? Down the groin area? No, it's just right there now. Okay, but it started more generalized. Yeah. On a scale of 1 to 10 last night, how bad was the pain? I would say a 2. A 2. And now, what would you say? 7. A 7. Okay. When it first started, were you doing anything in particular? Did you lift something? No, it was just this. Was there any trauma? It was just looking at the TV. Yeah. Right. Through the night, did it wake you up? No, I slept. You were able to sleep. Okay. Did you feel nauseated? This morning. Did you throw up? Yeah, an hour ago. Yeah. How's your appetite? Do you feel hungry? Do you want to eat? No, you don't. Okay. Did you have any fever? I did not take it, but now I feel kind of feverish. You feel a bit feverish. Did you have any night sweats last night? No. No chills when you were shaking? No, but this morning I saw it started. Okay. Tell me about your bowel movements. When was the last one? Yesterday morning. Okay. Was it normal? Did you have a period of time in the last week or so where you were either constipated or had diarrhea? No. Have you recently noticed any blood in your stools? No. Or any black diarrhea stool? No. Are you having problems with the bladder in terms of burning to urinate?
Ask relevant questions from anyone. So up till now, any questions related to the history taking from surgical perspective, surgical point of view, you can ask me. Sure. Yes. अरे मैं लेक्चर में था, आप बताएं. हेलो जी भाई साहब. नहीं अभी नहीं, बताएं. तो अभी तो मैंने कहा छुट्टी नहीं ले रहा, तो हाँ एंट्री पास कर दें, फॉर्म स्ट्रक्चर पास कर दें और फिजिशियंस ओपिनियन ले लें, फिर मैं देखता हूँ, ठीक है। हाँ ठीक है, इसको कर दें, ठीक है। ठीक है अल्टरनेट करते हैं, ठीक, ओके जी वही कर लेंगे, ठीक है, ओके। मैं आऊँगा मैं देखूँगा, ठीक है, ओके जी मेरे पास क्या फिजिशियन ओपिनियन लेना, फिजिशियन ओपिनियन, ठीक है, ओके। Yes, any questions up till now? Can you mute the mic so that anyone can ask questions related to the history taking? Are you boring at home, or you are very much willing to come in the ward? Can you write down your messages? Or chat? No. Exam ho jayega inshallah. Only thing that is worrying is you can just read it home, and you just ask questions. Yes, you want to come in the ward naturally. That is very important, because physically and online there's some differences, of course. But in the meantime, you should read today so that you should be very much familiar with the history taking and with the history of exam. You do the examination like general physical examination. But in the meantime, if there are any questions, please let me know. Noman, mic इनका on कर दें, mic. Again, if you are here, please let me know. You.
Student के mic.
My student के mic. You just raise the hand one by one, and then I will mute the mic. Yes.
वो अजगे में बंदा अजगे में जैसे इंटर होता है ना, सामने मुर्गे वाले हैं, उसी थोड़ा सा बंदा आगे रहता है, वो फ्रूट वाला सामने खुले मोटा।
If there are any questions, you just raise the hand. The mic is muted.
Not coming this way, right? Yeah, they're not coming this way.
Please raise the hand if there are any questions. It will be unmuted. Just raise the hand. Okay, if you don't have any questions, then thank you. Thank you very much. And the next class will be on the examination that will be taken by Dr. Munira. Okay, thank you. Thank you.